Okay.
It's like
A,
giving you a headache.
a 72-year-old man with a 10-day history of fever, nausea and vomiting, and progressive confusion, remain hospitalized because his symptoms have not resolved despite treatment with broad-based antibiotics. He has 6-year history of severe emphysema treated with course of corticosteroid. During the past year, medication include IV ceftriaxone, ampicillin, albuterol inhaler, theophylline, and prednisolone. He is confused and stuporous. His temperature is 102, pulse 84, blood pressure 142 by 86. Physical examination shows meningismus. An MRI of the brain shows diffuse meningeal enhancement with basilar predominance. Diffuse meningeal enhancement with basilar predominance. A lumbar puncture is done. CSF fluid analysis show a leukocyte count 86% and a glucose count concentration is 17. Glucose concentration is 17. A protein is 212. Which of the following is the most likely diagnosis?
Ready?
1 second. Yes. Ready?
Okay. It is tuberculous meningitis. Chronic use of immunosuppressant, including steroids, increase the likelihood of tuberculosis. Tuberculous meningitis typically presents with local rigidity, fever, alternate and status, similar to symptoms seen in bacterial meningitis. However, unlike bacterial meningitis, which presents acutely, tuberculosis typically shows a subacute presentation. Presence of cranial nerve palsy is also more likely in tuberculous meningitis than bacteria. Physical may show chronic sign in Brzezinski, indicative of meningeal irritation, results of lab will show non-specific changes, including leukocytosis and anemia. Tuberculosis skin tests on interferon gamma release assay are usually positive, but negative result is possible. CSF evaluation is the initial diagnostic step and will reveal increased opening pressure, increased white blood cell count, prominent lymphocytes, increased protein concentration, and decreased glucose. Culture of CSF for acid fast bicidal may be positive, though the sensitivity of this test for tuberculous meningitis is less than 50%. Radiologic eval may show bacillar exudates, as in this case, as well as periventricular infarct and hydrocephalus. Okay,
Okay,
next.
next. An 8-month-old girl is brought to the physician. An 8-month-old girl is brought to the physician by her parents irritability over because of increased irritability over the past month. During this period, she has had intermittent low-grade fever. She has had intermittent low-grade fever, episodes of stiffening her body. Her father reports that he previously interacted with them and smiled when prompted, but has not made eye contact for the past 3 days. She has a history of hypotonia. She cannot yet roll over and sit up. Her parents are third cousins. She is awake and irritable and has poor visual rigor. Examination of the child. Examination of the skin shows no neurocutaneous lesion. Optic nerves are pale. Neurologic examination shows hyperextension of the head and back and ankle spasticity and fisting. Deep tendon reflex are brisk. Babinski sign is present. An MRI of the brain is most likely to show which of the following. Hyperextension and ankle spasticity.
Ready?
Is it CP cerebral palsy?
I do not know this one.
Okay,
So is the generation of the white matter. This infant presentation of fever, spasticity, hypotonia, vision loss, optic nerve palate, Babinski sign, as well as family history of consanguinity are consistent with the diagnosis of Krabbe disease, also known as galactosylceramide lipidosis. Krabbe disease is autosomal recessive lysosomal storage disorder caused by mutation in the GAL-C gene that encodes galactocerebrosidase, the deficiency of which results in accumulation of galactocerebroside and the myelinating neuronal degeneration. Patients typically present within the first year of life with progressive neurologic degeneration, spasticity, stiffness, seizure, feeding difficulty, peripheral neuropathy, including optic neuropathy. The diagnosis is confirmed with serum enzyme assays, although MRI of the brain will show white matter degeneration caused by demyelination. This is no effect. There is no effective treatment for Krabbe disease. Most affected children die during the first years of life. Never heard this one. It's not holoprosencephaly. Congenital malformation in the prosencephaly does not divide into two hemispheres. Most cases result in a utero death and are also accompanied by craniofacial malformation, including cyclopia and the presence of proboscis. Lysosomal storage they are not taken now. It's not schizencephaly, rare congenital malformation characterized by cleft throughout the cerebral parenchyma between the ventricles and PMR, the lysosomal storage disease, blah, blah, blah. Okay,
next.
next.
A 57 year a 57-year-old woman is brought to the emergency department 20 minutes after a simple partial seizure. 20 minutes after a simple partial seizure. Examination shows mild weakness. Examination shows mild weakness of the right lower extremity. CT scan of the head shows 1.5 centimeter uniformly intensely enhancing parasagittal mass on the frontal region. Which of the following is the most likely diagnosis for parasagittal? Ready?
Give me a second. Yeah, ready.
Glioblastoma multiforme is a butterfly appearance, isn't it? And
Yeah, meningioma, a common benign CNS tumor derived from meninges that occurs along the surfaces of the brain and spinal cord, often in parasagittal region. They occur in women more than men associated with NF2 and MEN2. Patients may be asymptomatic, experience seizure or focal neurologic deficit related to tumor location. Meningiomas are benign but can be malignant. Malignant meningiomas may go rapidly, leading to Symptoms of increased intracranial pressure, postural headache, nausea, papilledema, or may metastasize. Meningioma appear as well circumscribed extraaxial, extraaxial outside the brain parenchyma. Masses that compress the parenchyma, they show uniform enhancement on imaging. Definitive diagnosis requires histologic exam of tissue, which will show spindle cells arranged in word pattern with plasma bodies. Treatment may include antiepileptics or surgical resection to alleviate the tumor masses. The tumor mass effect is significant, though often periodic surveillance is all that's necessary. It's not astrocytoma, primary CNS neoplasm occurs that can occur as benign polycystic astrocytoma in children or malignant glioblastoma multiforme in adults. Glioblastoma are highly malignant tumors appearing as intraaxial masses in the cerebral hemisphere, which typically show areas of necrosis can spread to the opposite hemisphere across the corpus callosum. I'm sure, no, I wasn't really sure, no. Oh, okay, that's it.
Okay, next. A 67 a 67-year-old semi-retired corporate executive comes to the physician with his wife because she is concerned about his increasing disorganization at home over the past year. She also notes that he is unable to remember the names of the recent acquaintance. He has insisted on working part-time since stepping down from a CEO position. His secretary told his wife that he had been forgetting scheduled appointment and become angry and tearful when he is reminded. He drinks 1 to 2 cocktails each evening. Physical examination show no abnormality. On mental status examination, she is mildly agitated and has a word finding difficulty and short-time memory deficits. He is oriented to person, place, and time. Which of the following is the most likely diagnosis?
Mm, Ready?
Yes.
Uh, wait, there you go. So it is dementia, Alzheimer. Alzheimer, the most prevalent dementia presenting with progressive cognitive decline that begins with short-term memory impairment, decline in visuospatial abilities, and progress to apraxia, language abnormality, and dysexecutive syndrome resulting in inability to recall scheduled appointments in this patient. The disease culminates in behavioral and personality change that prevent the patient from performing basic activities of daily living, such as bathing. Alzheimer may be treated with drugs that both directly and indirectly increase acetylcholine and synaptic. These include donepezil cholinesterase inhibitors, which non-competitively and reversibly inhibit acetylcholinesterase and thereby, yeah. Though these drugs may slow cognitive decline and modestly improve functionality, they are not curative. It is not Parkinson, characterized by tremor, rigidity, akinesia, and postural instability. Peak disease of frontotemporal is neurodegenerative disorder characterized by atrophy of the frontal and temporal lobe, causing deficits in social behavior and personality along with dementia. Normal aging includes a slow decline in executive function, attention span, and problem solving after 70. A successful aging individual should be able to still function in society. Sorry. Okay.
So why it is not multi-infarct or vascular dementia?
Nothing for the features stepwise cognitive decline following cerebrovascular incident. He don't have any risk factors for infarct.
Okay. 67 years, isn't it too early for the Alzheimer?
No, don't think so.
Okay. Next. A, a, a 17-year-old boy is brought to a 17-year-old boy is brought to the emergency department by ambulance 2 hours after dove into a shallow lake and struck the back of his head on the bottom. He immediately had the onset of pain in his neck and sensation of an electric shock radiating from his neck to his shoulder. He did not have loss of consciousness. He was able to stand, and two friends helped him out of the water in a supine position of the dock. At the scene, spine was his spine was immobilized with a cervical collar. His head was tapped to a his head was tapped to a backboard. On arrival, he is alert. Vital signs are within normal limits. Muscle strength 3 by 5 on extension of the left wrist. Deep tendon reflex on normal. Babinski sign is present. Babinski sign is present. Sensory motor examination of the upper extremity and the lower extremity show no abnormality. Sensation to the light touch is decreased over the radial aspect of the forearm and hand over the palmar and the dorsal aspect of the left thumb. Rectal examination shows normal sphincter tone and sensation. A lateral X-ray of the cervical spine is shown. The patient most likely has which of the following cervical spine injuries?
Hello, Omar.
Yes, can you hear me?
Hello.
Hello, hello. I am there.
Yeah, now.
You haven't heard anything?
No, I heard. I heard. It's just at the end that your voice went like it started cracking.
Okay. Now it's all right.
5, 6, 6. Ah, it's good. I said with engagement of the C5 nerve root. C5, C6.
Is it
Nothing else is visible.
spondylolisthesis, like forward slippage of one vertebra over another?
Yeah, but how does that help you to find out the answer here?
Look at the
Progressive
MRI.
passive
Sorry, look at
inhibition.
the X-ray. There is five in the 5 and 6. C5 is came forward, then the C6, and there is pars fracture probably.
Okay, but how does that? Okay, can you figure out the answer from that? Are you able to figure out?
Mm,
Okay,
no, it's tough.
and that's what I'm saying. I mean, we know it's spontaneous, but how does that? Do you figure out the answer from that? Okay, let's pick one at this point. I'm between C and E, but I know C5, C6 will affect the C6 will affect the thumb and the. Let me see. What did they say it affected? Blah 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 blah. Right upper extremity. Sensation to light touch is decreased over the radial aspect of the left forearm, C5, C6, yeah, over the palmar and dorsal aspect of the left thumb. C5, C6, yeah, that is C6. Ready?
Yes.
Okay, so it is C, bilateral dislocation of facets with impingement of the left C6 nerve root. This patient likely has bilateral dislocation of facets with impingement of the left C6 nerve root caused by cervical-spinal injury. C6 dermatom is located on the lateral radial aspect of the forearm and it extends to the lateral two digits of the hand. Yeah. Injury to C6 nerve root will cause decreased sensation, pain, and paresthesia in the distributions, along with motor dysfunction of flexion, elbow flexion, and wrist extension. The C6 nerve root carries efferent information from biceps reflex, so patients with C6 nerve injury may present with diminished or absent biceps reflex. Dermatomes and myotomes are components of the embryomesomite and pairs segment, whatever. When fully developed, the dermatome is an area of skin whose afferent fibers travel within a single spinal nerve. And myotome is a group of muscles innervated by efferent fibers from a single spinal nerve. This herniation and spondylosis are common cause of spinal nerve root compression in all patients, and trauma and consequent vertebral dislocation or fracture is a common cause of root compression in young patients. So just this patient. Sensory deficit, motor dysfunction, and pain typically occur in the dermatoma distribution. This relates to the affected nerve root. It is not E. I don't know where is E. Right here. Bilateral dislocation of facets with impingement of C5 nerve root. And unilateral dislocation of facets with impingement of C5 nerve will lead to sensory and motor dysfunction in the lateral aspect of the shoulder and upper arm. C5 nerve compression typically results in an absent biceps reflex. Okay. And C5 nerve root carries afferent information for this reflex. However, C5 nerve will not cause decreased sensation. Okay, makes sense. Next.
So how we can figure it out? This type of question.
It's just you need to know the dermatomes. You
Like
just need to
C6.
memorize it. I know. Yeah, the just the C ones. Um, I just try to because I found a lot of questions like this. So C5 will be all of this. C6 will be this one is not a good example. I don't know why this one is not. Oh, let me see. Maybe this one. Yeah, I guess this one will make things a bit better. Okay, so C5 is usually calculated from here to here. So upper arm. Then C6 will be this to the first two digits. So from here to the first two digits. And then C7 will be the third digit, this one, and all the back, like you see here, all the arm at the back, arm format. Then C8 will be the last two digits. And I think it's just the last two digits. I think so. And then T1 will be all of this. So every time they tell you, so here they tell you that he has pain or whatever, paresthesia, or all these things. He has it. I think
Sensation
they say
in
here.
here, according to this question, sensation to the light touch is
Yeah.
decreased over
Uh-huh.
the radial
Uh-huh.
aspect of the left forearm and hand. So it is C6 area
Yes.
is involved, and the
C6 area.
and
Yes.
the dorsal area of the left thumb.
Also area of the anyway, they try it's this one. The other option they're giving you is C5, but C5 will only cover from here to here. So it wouldn't include the hand. That's why it's C6, because it's including the hand.
Okay, thumb
Does it make
index.
sense?
Okay, yes.
It's because if, the way I memorize, I just do it with my own hand. C5, then C6, the forearm, C7. I don't know. It just makes sense when I do it with my own
Okay.
hand. Okay.
C6 is up to thumb.
It's up to the thumb and the first two. C7 is just the middle, the one middle, and then C8 is the last two.
Ring and in little finger.
Little finger.
And C5 is in the middle one, the middle portion of the body.
From here to here, here to here.
Okay.
Just this part. Mhm.
Only the arm, or it includes the forearm also.
No, here to here. The forearm is this. The arm is this. And the
Yes.
forearm is this. So C5 is only the arm. I guess
Okay.
shoulder and I guess if you want to say it like that.
Okay.
Mhm.
A A 62, a 62-year-old man, a 62-year-old man is brought to the emergency department 2 hours after sudden onset of headache and left-sided weakness. Sudden onset of headache and left-sided weakness that has become increasingly severe. He has hypertension treated with lisinopril and chronic neck pain treated with 375 milligram of aspirin. On arrival, he appears mildly lethargic. His pupils his pupil is 60 per minute. His pupil is 60 per minute, respiration 16 per minute. Blood pressure is 180 by 100 millimeter of mercury, 180 by 100 millimeter of mercury. Examination shows moderate weakness of the lower left side of the face. Examination show moderate weakness of the lower left side of the face. Muscle tone is decreased in the left upper and the lower extremity. Muscle strength is 4 by 5 on the left and 5 by 5 on the right. Deep tendon reflex 3 plus on the left. Babinski sign is present. Babinski sign is present on the left. A CT scan of the head which is the CT scan of the head without contrast is shown. Which of the following is the most likely diagnosis?
I do not know. Ready?
Wait 1 second.
Mhm.
Okay.
Hypertensive intracerebral hematoma. Hypertensive intracerebral hematoma can ICH and occur in patients with chronic hypertension, typically because of hemorrhage from small penetrating arteries in the bones, midbrain, thalamus, putamen, caudate, or cerebellum. Risk factors for hypertensive ICH include uncontrolled hypertension, antiplatelet, and anticoagulant therapy, such as with aspirin or warfarin. Patients can present with headache, vomiting, confusion, altered mental status, stupor or coma. Focal neurologic deficit depend on the site of ICH and it can include hemiparesis, hemisensory symptoms, gaze palsy, dysarthria, aphasia, or if the cerebellum ataxia, or if in the cerebellum ataxia, vomiting, disequilibrium, Patients may manifest open motor neuron examination findings such as plasticity, hyperreflexia, or extensive Babinski sign. Diagnosis is made with contrast CT scan of the head, which will show hyperdense intraparenchymal products, which is the appearance of acute bleeding in the brain as seen in this patient right hemisphere. It's not a cerebral amyloid angiopathy occurs secondary to amyloid deposition in cerebral blood vessels and the pneumonitis. It can cause spontaneous intracerebral hemorrhage in older adults, typically in a lobar location because of the location of amyloid deposits in cortical vessels. In contrast, hypertensive hemorrhage typically occur in deep locations such as the putamen thalamus. Hmm. Okay, and it's not ruptural arteriovenous malformation can lead to intracerebral subarachnoid hemorrhage. Arteriovenous AV malformations are uncommon and usually present in individuals younger than 50 with intracranial hemorrhage, seizure, in neurologic deficit, headache, and maybe an incidental finding in another patient with a controlled hypertension, hypertensive hematoma is more likely. Okay.
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 Over the past 6 months, an otherwise healthy 16-year-old cheerleader has had increasingly severe neurologic symptoms. Initially, he initially she had difficulty jumping. 2 weeks later, she had a tingling feeling in the toes of her right foot, tingling feeling in the toes of her right foot, and quickly spread to the left foot. Over the past 2 weeks, she has stumbled and fallen several times. Examination of the upper extremities shows small findings. Deep tendon reflex, small findings. Deep tendon reflex are absent in the lower extremity. Deep tendon reflex are absent in the lower extremity. She is unable to heel. Sorry, she is unable to heel walk, and has mild difficulty walking on her toes. She has unable to heel walk and has mild difficulty walking on her toes and rising from a low squatting position. Position sensation is normal, but pinpricks feels sharp distally and occasional light touch. Sorry, pinprick feels less sharp distally, and occasional light touch stimuli are missed over the toes. Peroneal motor conduction velocity is moderately slowed. Which of the following is the most likely diagnosis?
Mm, no, no. Ready? Hello?
Yes, ready?
Oh, yeah. Chronic inflammatory demyelinating polyradiculum. Yeah, CIDP is an autoimmune mediated demyelinating condition affecting the spinal nerve roots. The pathogenesis of CIDP involves inflammation of myelin by unknown mechanism. The ventral nerve roots containing motor efferent are commonly involved, though the dorsal nerve root controlling sensation may also be affected. As such, patients typically present with relaxing, remitting, or gradually progressive symmetric muscle weakness with depressed or absent deep tendon reflex, reflecting a lower motor neuron pattern of dysfunction. And that affects the proximal and distal lower extremities. Simultaneously, it may also affect the upper extremity. Autonomic dysfunction may occur, but is typically mild. Sorry, deficit may occur, though these symptoms are typically mild compared to motor. The slowing of conduction velocity on nerve conduction studies indicate demyelination and support the diagnosis. Diagnosis is further supported by increased CSF protein with normal cell counts on lumbar puncture. Term albuminocytologic dissociation and thought to reflect generalized inflammation. Management includes steroids, immunomodulated plasma, and change in IV immunoglobulin. It is not, I was between the Guillain-Barré also. Inflammatory demyelination polynuclear presents with acute onset ascending bilateral muscle weakness with hyporeflexia. Chronic time course is inconsistent with Guillain-Barré. So just because this is 6 months, I guess Guillain-Barré
Acute.
um, be acute. And it's not syringomyelia. Features a cystic cavity in the central spinal cord manifest with deficits in pain and temperature, sensation, and lower motor neuron dysfunction in the bilateral upper extremities. So problem in the hand, pain and temperature, and bilateral upper extremities. Okay, and it's not spondylotic myelopathy, refers to degenerative vertebral disease leading to spinal cord damage. The otherwise healthy young patient is unlikely to show vertebral degenerative disease, I guess. Okay, it's been going on for 6 months. Okay, next.
Okay. A 62, a 62-year-old man is brought to the emergency department progressive weakness progressive weakness of his leg during the past week. Progressive weakness of leg during the past week. He has chronic kidney disease and receives dialysis 3 times weekly via percutaneous tunnel catheter. Last week, he had an episode of sweating and chills. He had an episode of sweating and chills. Her temperature is 102 pulse 100 per minute regular. Blood pressure 150 by 90. Examination shows severe tenderness to percussion over the lumbar spine. Examination shows uh, tenderness to percussion over the lumbar spine. The catheter appears normal. There is stress edema of the lower extremity. Muscle strength is 3 by 5 on flexion and extension of the knee and the ankles. Deep tendon reflex are increased at the patella. Deep tendon reflexes are increased at the patella. Lab examination hemoglobin 11, leukocyte count 19,200, segmented neutrophil 90%, bands 5%, eosinophil 1%, lymphocyte 4%, platelet count 2 lakh 90,000. An MRI of the spine shows epidural abscess and the L4 blood culture shows staph aureus in addition to uh, antibiotic therapy and drainage of the abscess. Which of the following is the most appropriate next to management? Mm, mm, mm. Ready?
Mm-hmm. So it is Removal of the catheter. Epidural abscess is localized collection of pus in the epidural space between the dura and periosteum. It most commonly occurs in spine, but may occur in the brain. Most patients have history of another preceding or associated event, infection, and often have a history of immunocompromise like diabetes, HIV, alcohol use. Epidural abscess is more common in patients with a history of IV drug use or indwelling intravenous line. Infectious organisms usually spread to the epidural space hematogenously from spinal surgery or from adjacent osteomyelitis. Staph aureus is frequent causative agent. Patients present with signs and symptoms of fever, athermia, status, meningitis, localized back pain and tenderness to palpation, along with weakness, numbness, and paralysis below the affected spinal level. Um, as a result of core compression, treatment is with full-spectrum antibiotics, surgical drainage of the acid. It is crucial to identify and remove potential sources of bacterial colonization, such as indwelling venous catheters. Next,
A 67-year, sorry, a
did
60,
not say anything.
okay, a 67-year-old man is brought to the emergency department by his wife after 30 minutes after a 15-minute episodes of inability to speak. He has 15-year history of poorly controlled hypertension. 3 weeks ago, he has had transmural myocardial infarction. He has a transmural myocardial infarction and underwent placement of stent in the left anterior descending artery. Current medication include clopidogrel, benzapril, 81 milligram aspirin. He has smoked 2 packs of cigarette daily for 30 years. On arrival, he is alert, oriented to person, place, or time. His pulse is 60 per minute, respiration 15 per minute, blood pressure 160 over 100 millimeter of mercury, A grade 1 by 6 systolic murmur. A grade 1 by 6 systolic murmur is heard based at the second intercostal space. Heart based at the second intercostal space. Neurological examination show no focal findings. Carotid duplex ultrasonography show 40% stenosis of the else 40% stenosis of the left carotid artery. Which of the following is the most likely diagnosis?
Ready?
Wait 1 second. Mm, mm. Okay.
Okay, so it is embolus from a ventricular aneurysm. An embolic ischemic stroke involves an event in which a clot breaks off and travels to the brain, occluding blood flow within a cerebral artery. Emboli can originate from proximal vessels such as the internal carotid artery or from an atrial or ventricular thrombus. This patient had a recent MI which predisposed him to ventricular aneurysm. Ventricular aneurysm are more likely to form in the case of large anterior myocardial infarctions as a result of obstruction of the left anterior descending artery, as was the case of the patient. A small systolic murmur of mitral regurg may be heard within the aneurysm. Within the aneurysm, as a result of areas of stagnant blood flow and despite being copidogal, thrombus can form dark and embolize and cause ischemic stroke. If a patient foramen ovale is present, if a pattern foramen ovale is present, an embolism may arise from either the right or left side. This patient also has other risk factors for ischemic stroke, including hypertension, atherosclerotic disease, because his symptoms resolve within less than 24 hours. His embolic event is classified as a transient ischemic attack. It's not the infarct of the lacunar artery causes ischemia due to deep cerebral white matter Mhm.
Pons. Or
Pons and basal ganglia. A lacuna straw may present with polymotor symptoms, purely sensory symptoms, ataxic hemiparesis, and dysarthria. In parts of these deep penetrating vessels are secondary to hypertension, diabetes, hypercholesterolemia. While this risk factor will also predispose to MI, this patient transient ischemic attack is most likely caused by embolism from the left ventricle as opposed to primary central venous system infarction. Hmm, it doesn't make much sense. Okay, it's not where was I? Intraparenchymal cerebral hemorrhage or subarachnoid hemorrhage are both causes of hemorrhagic stroke and are caused by rupture intracranial or subarachnoid blood vessels in the setting of hypertension. CT scan of the head without contrast is typically obtained in the acute setting to confirm the presence of blood. Transient ischemic attack is not caused by hemorrhage. It's not spasm of cerebral artery. It's a potential complication of subarachnoid hemorrhage which tend to occur like 4 to 10 days after the initial bleed. Leads to subsequent ischemia in the area supplied by the spasm artery. Is not the cause of this patient transient ischemic attack. Okay, next.
next. 1 month after starting isoniazid and rifampicin therapy for pulmonary tuberculosis, a 62-year-old man develops weakness, fatigue, and paresthesia. She also she shows pallor and diminished light touch to the extremities. Lab studies show hemoglobin 9, IMCV 78, leukocyte count 8,000, and platelet count to like 10,000. Symptoms most likely respond to which of the following? Ready?
Yes. So it's vitamin B6, isoniazid, and rifampin are used in treatment of primary TB for Mycobacterium TB. Isoniazid binds vitamin B6 pyridoxine, which may result in early excretion and activation of pyridoxine, and also inhibits pyridoxine phosphokinase, which is necessary to activate it. Pyridoxine um, deficiency results of which primary symptoms are peripheral neuropathy and paresthesias. Pyridoxine deficiency limits synthesis of histamine, hemoglobin, and neurotransmitter including epinephrine, norepinephrine, dopamine, serotonin, GABA. In addition to peripheral neuropathy deficiency, commonly presents with dermatitis, sideroblastic anemia, bursitis, and seizures. This adverse effect may all be avoided by pyridoxine supplementation in all patients taking isoniazid. Not iron deficiency also presents with microcytic anemia, however, is not induced by isoniazid or rifampin. Any supplementation will not address the symptom of pyridoxine deficiency. Okay, next.
Okay. a 22-year a 22-year-old man who is a collegiate volleyball player comes to the physician for 2 month history of progressive pain and weakness of the 2 month history of progressive pain and weakness of the right shoulder. There is no history of trauma. He is 6 feet 5 inch tall, weight 95 kg, BMI 25 kg per meter square. There is significant loss of muscle mass in the dorsal scapular region, especially in the area of scapular spine. Passive abduction and external rotation of the right shoulder. Passive abduction and external rotation of the right shoulder and protection of the scapula reproduce the pain. There is weakness with restricted external rotation. There is weakness with There is weakness with resisted external rotation and initiation of abduction. So resisted abduction and external rotation. Active and passive range show full flexion and adduction. Sensory examination show no cutaneous deficits along the right side of the neck or the right upper extremity. Which of the following is the most likely symptoms?
Axillary nerve damage, weakness in sternal suprascapular
Tennis, minor, as well
rotation,
as
initiation of abduction, flexion and abduction. Hmm, what's this one? Ready?
yes.
So it's irritation of suprascapular nerve. Patient symptoms and physical exam findings are more consistent with entrapment of suprascapular nerve. The suprascapular nerve originates from the superior trunk of the brachial portion in nervates to supraspinatus and infraspinatus nostrils. Nerve compression secondary to traction. Injury is common among volleyball players. Irritation of the suprascapular nerve results in pain along the course of the nerve and may result in chronic neuropathy with subsequent muscle wasting, atrophy, and degeneration of the infraspinatus or supraspinatus muscles. The supraspinatus is responsible for adduction of the shoulder, and the infraspinatus is responsible for external rotation mm, of the shoulder, which reproduce the pain and disclose weakness in this patient. Okay, I think they wrote it wrong here. Our initial treatment is conservative with activity modification and physical therapy. Operation may be required. It's not axillary nerve damage, results in weakness of the deltoid and teres minor, which abduct, abduct, and stabilize the shoulder. The axillary nerve gives rise to superficial lateral cutaneous nerve of the arm, and sensory deficit would be expected if injured. Makes sense. Okay. Okay.
Next, a 32-year-old woman comes to the physician with her husband because of 6 months history of fluctuating symptoms, including fatigue, loss of balance, blurred vision, and the sensation of the pins and needles over the arms and the legs. Her husband says that her husband says that she has also had no mood swings with episodes of uncontrollable crying over the past 2 months. Her temperature is 37 degrees Celsius, pulse 80 per minute, respiration 60 per minute. Blood pressure is 128 by 86 millimeter of mercury. Neurologic examination show reduced medial gaze of the left eye and numbness and pinprick over the distal lower extremity. Romberg sign is present. Babinski sign is present on the left. Which of the following is the most likely diagnosis? Which of the following is the most appropriate next step in diagnosis? Cage, numbness.
Yeah. Ready?
Sorry.
Ready? Sorry.
Yes.
So it's MRI of the brain. MS, the most prevalent immune-mediated demyelinating disease, may present with episodic or progressive neurologic dysfunction. According to McDonald criteria for MS, patients must have evidence of demyelinating lesions that are separated in time and location. This evidence is typically based on subjective symptoms or radiologic studies. Lesion affecting the left medial longitudinal fasciculus leading to medial gaze of the leg, whatever. The prefrontal cortex or corticobulbar tracts leading to pseudobulbar effect of uncontrollable crying, and the major CNS tracts innervating the extremities, lesion of the corticospinal, Babinski signs, phenothalamic, blah blah blah, are likely separated in space. This patient experienced two discrete periods of symptom onset at 6 months and 2 months, illustrating separation in time. MRI typically shows white matter hyperintensities in the periventricular region, cortex, subcortical region, cerebellum, spine, oligoconal antibodies. Oligoconal bands of immunoglobulins indicating immune overactivation can be found in the CSF, but not necessary for diagnosis. Treatment includes steroid for symptomatic management, for acute flares or long-term of acute flares or long-term modifying treatment such as interferon of antibodies. Is not the measurement of copper concentration diagnoses Wilson disease in which copper accumulates in the liver, brain, and eyes. Though mood swings and extrapyramidal symptoms may occur, months of medial gaze palsy along with sensory motor dysfunction will be atypical. Okay.
Okay. Next,
Mhm.
a physician makes a house call for 87-year-old woman who is unable to come to office difficulty with difficulty with transportation. Our family reports that she has fallen frequently during the past 6 weeks. She has fallen frequently during the she has fallen frequently during the past 6 weeks. The patient says that she has had difficulty when her feet are she has had difficulty when her feet are but when her feet are but she has otherwise on well. She has not had loss of consciousness exam. She has no history of serious illness, takes no medication, vital signs are within normal limit. Muscle strength is 4 by 5 on flexion of the hips and the extension of the knees and ankle bilaterally. Proprioception and sensation to vibration are decreased on the lower extremity. Sensation to the light touch is intact. She has slapping gait. Mental status show no abnormalities. The physician counsels that the patient about making enhancement to her home to prevent fall. Which of the following is the most appropriate next step in the diagnosis?
Ready?
Wait. Uh, okay.
Okay. So it's measurement of B12 concentration. Subacute combined degeneration caused by demyelination of the dorsal columns, lateral corticospinal tract, and spinocerebellar tracts is a feature of vitamin B12. Subacute combined degeneration causes a combination of motor and sensory symptoms, including gait ataxia, taxi gait, muscle weakness, paresthesia, and loss of proprioception and vibration. Muscle weakness, corticospinal. Okay. The effects of these features may include frequent falls, and in this case, B12 deficiency is often a result of inadequate dietary intake seen in veganism, malabsorption, pernicious anemia. Occasionally, all patients with poor nutrition may develop B12 deficiency. Other manifestations include dementia, megaloblastic anemia, in elderly patients with acute or subacute changes in behavior or activity of daily living, organic causes such as vitamin deficiency should be ruled out.
Okay,
Mhm.
next. It,
The lateral corticospinal carries what? Is it the one that carries pain and temperature? No.
pain
The one that,
temperature, yes.
wait, is it the lateral cortex or is it the spinothalamic? No, it's not pain and temperature. Corticospinal is,
Corticus,
mm,
wait. Spinothalamic, lateral spinothalamic tract may be pain temperature. Or
corticospinal.
corticospinal is maybe like contralateral paralysis. Am
Okay,
I saying right?
I think so. Okay, next.
A 27-year-old newly gravid woman had a calf or late spot and multiple neurofibroma. Since birth, a diagnosis of the neurofibromatosis is made. She is concerned that she might pass his condition off her children. Her parents, her parents, and three siblings do not have the disorder. Her parents, three siblings. The risk of neurofibromatosis in her children is closest to which of the following?
Mm, no, is it autosomal dominant? I don't know. Neurofibromatosis. I don't know. Maybe autosomal recessive. Ready?
Ready?
Yeah. So it is autosomal dominant, 50% chance for a child. Neurofibromatosis type 1, genetically inherited disorder caused by defect in NF1, the gene which encodes neurofibromin on chromosome 17. It follows an autosomal dominant pattern of inheritance characterized by constellation of cutaneous manifestation, neurofibromas, scapular spot, axillary freckling, and a variety of CNS system tumors, including optic nerve glioma, iris hematomas, bony abnormalities such as long bone dysplasia, sphenoid wing dysplasia. Patients are also at higher risk for developing astrocytomas, brainstem gliomas, and soft tissue sarcomas. Because it follows an autosomal dominant pattern, only one allele is needed to develop the condition. Thus, the chance of passing this patient passing the autosomal dominant blah, 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 is 50% for each child. It is not 25% for each child would be the chance of child developing autosomal recessive disease if both of his parents, if both his or her parents is anything autosomal dominant. And it's not E. What is it? While the patient likely does represent a new mutation, given that her parents are unaffected, this does not change the patient risk for passing on the permutation to her children. Okay, next.
Look at the figure and
Hmm.
tell you diagnosis. Okay, I'm reading the question.
No, I can tell it.
Okay, but it's a
This one.
sorry.
That, oh, sorry. Can you see my screen? At the
Yes,
central
yes, yes,
retinal
yes.
artery of
What have you found in the fundoscopy?
everything is whitish, so there is no blood coming in. And then there is this little thing. I feel like it means something. I just don't remember.
Cherry red
But the
spot on
fact
the
that
macula.
everything, yeah, but the fact that everything is whitish means that there is no blood coming in.
Okay, okay.
So, do you agree with me or you want to read?
Yes,
You agree with
I think so. We are right.
me? Okay. You want to check?
Yes,
Okay.
no need to
Mm.
read the question.
Okay. You sure? Okay, fine. I'll read the explanation. Patient
Yes,
presenting
this
signs,
type of question we need to find out from the fundoscopy or other finding.
during the exam, I would have read it. I would,
It would be
I'm not,
helpful. I-
it would have
Like
read it.
in the question stem, the first line is only important. Like sudden onset visual loss, and is it painful or painless visual loss? If it is painless vision loss, then Crow is the diagnosis. Like central retinal. The, this part is only need to be read. The rest
Mhm.
of the waste of time. Okay.
Okay. This, let me read the explanation. This patient presenting signs and symptoms of broad painless vision loss, well-founded with normal fovea color and consistent with the crown. Crown commonly occurs as a result of embolic occlusion of the central retinal artery, but may occur secondary to vasculitis such as giant cell arthritis. Patients may have history of preceding amaurosis fugax. Exam shows profound diminished visual acuity, relative afferent pupillary defect, and pale fundus with preserved fovea color. What's the fovea? What is it like? I don't know. But anyway, cow is medical emergency as it's an ischemic stroke of the ophthalmic vasculature and indicates a high risk of associated ischemic stroke of the brain. Patients who present with CRAO should be admitted to a stroke center for emergency evaluation, including a search for possible embolic source with echo and duplex ultrasound of the carotid artery, a careful history and lab evaluation, ESR, serum, CRP, should be and platelet count should be performed for possible GCA. There is no proven medical or surgical therapy for CRAO.
Okay. That part where the cherry red is present, that one is the phobia, isn't it?
Yeah, but how do they know that the phobia is fine here? I don't know. I guess since this one is fine, I guess. Yeah. Okay. Next.
Okay. A 52-year-old woman comes to the physician because of facial numbness for 2 weeks. Her symptoms begin as funny feeling over a patch of skin on the left side of the chin and have gradually progressed to novocaine sensation and has gradually progressed to novocaine sensation. She has had no facial pain, numbness of the gums or oral mucosa. She has a 3-year history of breast cancer, metastatic to the lungs and treated with tamoxifen. Examination shows supraclavicular adenopathy. Sensation to pinprick, light touch, temperature is absent. Sensation to pinprick, light touch, and temperature is absent over the left side of the chin. Neurologic examination shows no abnormality. Which of the following is the most likely diagnosis? Which of the following is the most likely location of this patient's abnormality? Sensation to pinprick, light touch, mandibular is absent.
Ready?
Wait 1 second. Is it cavernous sinus thrombosis?
I don't think so, but maybe.
Which of the following is the most likely location? Or it is trigeminal nerve involvement.
I think so.
Okay. I- Is it trigeminal neuralgia type of thing?
Let me see. Is mandible numb chin or mental neuropathy is an indication of bony metastasis to the mandible in this patient with history of breast cancer. Mandibular V3 branch of the trigeminal nerve passes through the bony canal of the mandible, branches to form the inferior alveolar nerve, and branches again proximal to the mental foramen to form the mental nerve. Mental nerve branch affected by mandibular bony metastasis provides sensory innervation to the ipsilateral skin of the anterior chin. Um, Another unaffected mental nerve branch provides sensory innervation to the ipsilateral lower lip and buccal gingiva. Compression of the mental nerve branch by bony metastasis of the mandible leads to anesthesia of the chin. Numb chin syndrome may indicate systemic malignancy, autoimmune disease, multiple sclerosis, or may be related to local infection, trauma, or dental disease. This patient should receive full body imaging to evaluate for metastatic spread.
Mental neuropathy. So
Okay.
supraclavicular. In Namchin syndrome, the sensation uh, would happen in the mandibular region, just like okay,
Mandibular mm,
okay,
mm,
kinda trigeminal
okay.
neuralgia. Okay, next. A 30, a 32-year-old woman with AIDS come to the physician because of 2-week history of painful burning sensation in her hands and feet. Examination shows no abnormal. Neurologic examination shows no focal finding. Which of the following is the most appropriate initial pharmacotherapy? Painful burning sensation in the hands and the feet. Ready?
Yeah. So it is oral nortriptyline. Peripheral neuropathy is frequent finding in patients with HIV and may occur either secondary to direct viral infection of peripheral nerve or secondary to neurotoxicity associated with antiretroviral nucleoside, uh, frequently medications in the NRTI class. HIV associated neuropathy most frequently presents with symmetric distal polyneuropathy, characterized by sensation of burning, tingling, numbness in the stop globin distribution, as well as reduced vibration and pimping sensation. As with other forms of distal polyneuropathy, TCAs such as norepinephrine are effective as first-line treatment. Other effective treatment is gabapentin, pregabalin, amotregine, and topical capsaicin or lidocaine. It is not topical lidocaine to the affected area is not the initial best pharmacotherapy for peripheral neuropathy because they are less effective in comparison with systemic or oral therapy such as TCAs. Okay.
Next, a 37-year-old man comes to the physician because of 1 week history of moderate low back pain. He thinks he thinks he thinks he may have hurt his back. He thinks that he may hurt his back while doing yard work. His pain moderately improves with rest. He has been spending a great amount of time in his bed. He has not had other symptoms, weight loss, and a recent infection. He has no history of serious illness. His only medication is ibuprofen for the pain. He does not use IV drugs, anabolic steroid. He is 178 centimeter tall, weight is 102 kg, BMI 32 kg per meter square. Examination show mild paraspinal muscle tenderness. Neurologic examination shows no focal findings. Which of the following is the most appropriate next step in the management?
Ready?
1 second. Okay.
So is continued ibuprofen therapy. Low back pain is a common presenting complaint, and it can be difficult to identify an exact cause. Most non-specific low back pain is attributed to musculoskeletal injury from exertion of a use of trauma. The majority of these cases will resolve with conservative management, which include activity modification, stretching, over-the-counter analgesics such as NSAID, massage, acupuncture, and heat therapy. Certain red flag signs and symptoms should prompt more urgent evaluation for the cause, specifically if there is concern for infection, malignancy, or fracture. These include new fevers, IV drug use, focal neurologic deficits such as urinary retention, saddle anesthesia, bowel incontinence, progressive lower extremity neurologic symptoms, current or recent cancer history, advanced age, systemic steroid use, and a significant traumatic mechanism. In this young, otherwise healthy patient with a mild inciting event, next best step is continuation of ibuprofen. Next.
Okay. A 37-year-old woman comes to the physician for a follow-up of 3 weeks of operative repair of the circle of Willis Berry aneurysm. Her husband says that her behavior has changed since the operation. She is unmotivated, just sits around all day like a bump on a log. She has not had depressed mood. Examination shows hypermotor retardation. She is oriented to person, place, and time. She is cooperative, but her speech is fluent and grammatical. But there is spontaneous speech during conversation. Which of the following is the of cerebral cortical region is most likely affected. Is she spoken her speech is fluent?
Ready?
Yes.
So it is frontal. Patient is exhibiting signs, symptoms of frontal lobe dysfunction. Frontal lobe is the largest lobe of the central cortex, cerebral cortex, separated from the parietal lobe by the central sulcus. Central sulcus. The major areas of the frontal lobe are the primary motor cortex, premotor cortex, and prefrontal cortex, Broca area, and the frontal ital. Symptoms depend on the location of the lesion. Involvement of the primary motor cortex or premotor cortex result in impaired motor function in the contralateral side of the body and psychomotor retardation. Disruption of the Broca area cause expressive aphasia with retention of language comprehension. Lesions of the frontal eye field result in the ipsilateral deviation of the eyes. Dysfunction of the prefrontal cortex can result in disinhibition, apathy, personality changes, aggressive behavior, and impairments of judgment, concentration, and orientation. And patients should be evaluated for other medical causes of cognitive impairment, such as B12 deficiency, hypothyroidism, syphilis, intoxication. This patient with recent invasive procedure, CT scan, or MRI of the brain is likely. It's likely to show the diagnosis. It's not insular cortex lesions may result in impairment in emotional and sensory processing, motor control, and speech. Patient may display progressive expressive dysphagia characterized by non-fluent or grammatical incoherent speech. And it's not DNE. Parietal lobe dysfunction lesions manifest differently depending on the side. Dominant parietal lobe dysfunction, most commonly the left side, may result in Cressman syndrome characterized by graphia, aphasia, agnosia, calcula, and right-left confusion. Non-dominant parietal lobe lesion typically presents with a neglect of the contralateral side. And then it's not temporal lobe lesions may involve Wernicke area, the limbic system, and amygdala. Wernicke area lesions result in receptive aphasia with loss of language comprehension, disruption of the limbic system. Um, oh, sorry, I have to pick up this
Yes.
call. Okay,
Let's take a break.
okay.
Okay.